and dignitaries present. I welcome you all to my presentation. I am from Bangladesh. You can see the picture of Royal Bengal tiger, who is a symbol of Bangladesh. The topic title is Comparison of Chronic Suppurative Otitis Media in Rural and Urban Primary School Children in Bangladesh. This was a field study, and this study was published in JLO in 2014. First, the introduction. We all know that chronic suppurative otitis media is a common community disorder in childhood in all developing countries, including Bangladesh. It may cause significant delays in speech, cognition, educational and psychological development. It is a typically persistent disease, insidious is on onset, and causes severe destruction and irreversible damage of the middle layer, and manifest usually with discharge and deafness. We can see the risk factors. Poverty is one of the important risk factors. Others are overcrowding, poor hygiene, lack of breastfeeding, male sex, passive smoking, poor nutrition, bottle feeding, nasopharyngeal colonization with potentially pathogenic bacteria, inadequate or unavailable healthcare, eustachian dysfunction, and so many. In Bangladesh, we have got a lot of rivers and canals, and in bathing in the rivers and canals and ponds allow the contaminated water to enter in the middle layer through the perforations of the tympanic membrane before they had time to heal. Otoscopy findings includes a perforation with or without otorrhea. CSM has been classified into tubotympanic and eticoantral variety, and eticoantral disease is associated with cholesteatoma. You can see the perforation, this tubotympanic type, central perforation, and this is eticoantral perforation with cholesteatoma. Prevalence of CSOM in Bangladesh was reported in last 3 decades to be 7.39% to 9.50%. Recently, researchers found that 12.44% of the rural primary school children aged 4 to 13 years were suffering from CSOM, and most of them were from lower socioeconomic group. Majority of the patients of chronic ear disease came from the communities living in the subsistence, agricultural or slum areas in Nigeria. Recently in Bangladesh, researchers concluded that 8% of the rural and 2% of the urban population had CSOM. In Nigeria, 6% of the rural school children had CSOM, whereas no case were found among the urban primary school children. In a Tanzanian survey, 9.44% rural and 1.3% urban children had CSM, which was significant, statistically significant. In New Delhi, in a survey, it was found that 19.6% of the children of lower socioeconomic group had ear disease, whereas in urban group with higher socioeconomic condition, there is 2.13%. Most of the studies on CSM were done on the prevalence and risk factors either of the rural group or the urban primary school children. There are only few studies to compare prevalence of CSOM in rural and urban primary school children. The aim of the study was to determine the prevalence of CSOM in rural and urban primary school children in Bangladesh, and to see and compare the association of CSOM of rural and urban primary school children with certain socio-demographic factors. These are parents, guardians, occupation, annual income, housing, total family members, sanitation, maternal education, and bathing habit. This was a cross-sectional study. Population were the primary school children from 2 primary schools of rural area and 2 from urban area, 1 from Dhaka metropolitan city representing urban group, and other from districts of Noshingdi, 2 primary school children of rural area. Random sampling of the schools were done. Study period was from July 2010 to December 2010. Sample size 681 rural children and 964 urban primary school children. After taking written informed consent from the parents or guardians, clinical ENT checkup and otoscopy examination of the sample population was done by the doctors trained in ENT. And their parents and guardians were interviewed regarding their occupation, parents' annual income, housing, total family members, sanitation, maternal education, bathing habit, and we used a pre-tested questionnaire. Presence of perforation in the tympanic membrane with or without otorrhea was taken as an evidence of CSOM. Recent traumatic perforations were excluded. No microscopic confirmation was done. In our terminology, we used housing categorized in as per our terminology, like Kacha, who has a house with mud in floor and walls and with a non-brick roof. Semi-Paka means floor is brick and walls and roofs are non-brick. Paka means floors and walls are brick, roof may be brick or non-brick. Ethical clearance were taken from the competent authority. Data was analyzed using SPSS. An appropriate statistical test for significance were applied. A p-value less than 0.05 was considered statistically significant, and less than 0.01 was considered highly significant. You can see the two places, a red mark where the study was done. These are the two places in Dhaka, and in rural is Noshingdi. Distribution of rural and urban children, we see that there is more urban children than the rural children. This is the distribution of male and female children in rural and urban group. In the rural group, there is more female children, slightly more. In the urban group, there is slight male dominance. We can see that there are 41 cases of CSOM in rural group from 681, in urban group 20 cases of CSM out of 964, and total 61 cases of CSM out of 1645. We can see the percentage of CSM. We can see that in cases of rural group there is 6.02% CSM, in cases of urban group 2.07%, and in cases of overall 3.71%. This is the prevalence of CSOM. As we can see the guardian's occupation and the relationship of CSOM, we found that there is a statistically significant association of CSOM with guardian's occupation. This table says that there is also a significant association of annual income of the guardian with the prevalence of CSOM. If we say that we categorize family small and large, this is an example of a small family, this is a big family, and family size is also significantly associated with the prevalence of CSOM. This is a Kacha house, this is a semi-Paka house, and this is a Paka house, and we find that there is also a significant association of prevalence of CSOM in rural and urban areas with housing. Maternal education has got statistically significant association with prevalence of CSOM. This P is 0.027%. This is a sanitation type. This is unsafe sanitation, and this is safe sanitation. Though sanitation was an important factor, but there is no statistically significant association of CSOM with prevalence of CSOM. Bathing, we categorized bathing in river, canals, or open water source, and the safe sources are tube well supply water, and there is statistically significant association of CSOM with bathing pattern. Now the discussion. The higher prevalence of CSOM of the rural primary school children compared with the urban ones is consistent with recent studies in both in Bangladesh and abroad. Though male sex was reported to be one of the risk factors of CSOM, but relatively higher prevalence rate of CSOM in this survey among girls can be explained by social and familial attitudes to them in our community. There was, as I mentioned, there was statistically significant association of parents, guardians, occupation, yearly income, housing, total family members, maternal education, and bathing habit with the children having CSOM of the rural and urban community. Though sanitation is an important risk factor for CSOM, but there is no significant association of sanitation with the children having CSOM of the rural and urban community in this study. Conclusion: improvement of the socio-demographic status and living condition would reduce the prevalence of CSM in primary school children in Bangladesh. Primary ear care education to the students, teachers can prevent vulnerable children from developing hearing impairment and its resultant complication. Thus, our future citizens would be safeguarded from the preventable burning problem of CSM. We acknowledge the Faculty of Postgraduate Medicine in University of Dhaka, Bangladesh, as this was my master's thesis. They permitted me to disseminate this. I acknowledge data collectors and statisticians, my thesis guide Professor A. F. Mohiddin Khan, and my wife Dr. Saiful Nahar, and my daughter. Thank you.
Thank you very much for the very beautiful presentation coming from Bangladesh. Well done, sir.
This is the beach of Cox's Bazar, which is the longest sandy beach in the world. Thank you.
Okay. So we entertain comments and questions. And I want to please elicit a plea from the audience. People present and they leave. So the young lady now, I know she came with him, right?
Yeah.
I saw you take some pictures. My plea is that after this presentation, you don't disappear, so that it won't just be me and the screen that is left here. Please, it's a plea. So, sir.
Thank you.
So, comments, questions? Now, my own question, sir. I've also done some work on preschool hearing loss in children. I'm curious about the immunization status.
Yes.
Did you look out for anything like the immunization status, as part of the predisposing factors? I was just curious to see if there's a correlation between the immunization status of them in both primary, because that is the factor that it cuts across the two age groups.
Yes, in our country, there is a program for immunization. We called it EPI schedule, Expanded Program for Immunization, and it is highly successful in Bangladesh. Almost 99% of the children have been within the cover of EPI schedule. And in this study, we didn't consider it, but we have got another study of our colleague. They found that immunization, those children who have been immunized with full immunization schedule, all the EPI schedule, they have got less number of children having CSM, and there was significant association of immunization and prevalence of CSM.
Thank you very much, sir.
Thank
Any
you.
other comments? Can please have your seat and don't leave, sir.